Sure. So I have the distinct pleasure today of introducing Dr. Carol Jones, who's going to give our grand rounds today. Carol did her undergraduate education at UNC in psychology. She has a minor's in both chemistry and Spanish for the professions. And did her medical school training at Brody School of Medicine at ECU in Greenville. She joined us 3 years ago. She can't believe time has flown, and here she is almost ready to graduate from our pediatric residency. We all know Carol's a dog lover and a true baby lover. She's a traveler, she's a great shopper, and above all, she's an excellent pediatrician who's going to talk to us today about adolescent acne.
Carol, it's Lantz. Can everybody hear me? I know that everybody's trying this new online thing. It's my first time doing it as well. So for those that don't know me, I am Carol Jones. I am a third-year resident, graduating in about a month, so we're getting close to the end. So as Dr. Lantz said, today I am going to talk about adolescent acne. I have no relevant relationships, affiliations, any disclosures. See, why is it not? There we go. So my objectives for today, we're going to talk about different types of acne with a special emphasis on distinguishing features. We'll look at the pathophysiology of acne and then talk about different lifestyle modifications that may help, and then different treatment options for the different types of acne. So just at a glance, excuse me, these are the different types that we'll discuss. Primarily, we're going to focus on adolescent acne, but I am going to briefly touch at these other types because acne does kind of exist across the span of childhood. So to start, what is acne? It's a disease of the pilosebaceous unit characterized by a long-term course with recurrences and relapses. So it's not something that comes, is that better with sound? It's not something that comes and you give a medicine and it immediately goes away. It kind of comes and goes over a longer period of time. This does affect up to 85% of adolescents and can persist into 20s and 30s and really and beyond. But you have to pay a specific attention to psychological sequelae because it does tend to happen at a time that appearance is acutely important. It happens primarily at the onset of puberty, and so it's a very noticeable disease. It's very visible, and it can be distressing to a teenager. And then that embarrassment can lead to lower self-esteem and feelings of unattractiveness and worthlessness. So it is important to pay attention to that aspect of the disease. This is a very kind of simple schematic, but I think it breaks it down a little pretty nicely. You kind of, is what I found is that acne generally is kind of a continuum. So you have comedonal acne, so with closed and open, so your whiteheads and blackheads. And then that's leading into more inflammatory acne where you have papules and pustules that are surrounded by erythema and more inflammation. And then that can progress into nodulocystic acne with large, red, angry nodules and cysts. And then just to put that into words a little bit more, generally, the first lesion to appear is called a microcomedone, so it's very small, not very noticeable. That will then evolve into non-inflammatory lesions of these open and closed comedones or blackheads and whiteheads. And then inflammatory lesions manifest as papules and pustules, and they can occasionally develop into nodules, which is considered very severe disease. These can present in combination with varying degrees of healing and development. So you'll have lesions that are brand new. You'll have some that are healing. You'll have some that are on their way up or out. So it's not like this all happens at once and then goes away at once. And these generally appear where there's an increased density of pilosebaceous units, which tends to be in this T-zone distribution, which is kind of across the forehead and down the middle of the nose into the lips and chin. And this is correlated with the onset of adrenarche due to the increased release of androgens at that time. So this is just to show that T-zone. It's the brow, the glabella, the bridge of the nose, and then it can extend down to the chest, shoulders, and back as well. So quickly, does anybody know what we're looking at here? If you saw this in clinic, what would you tell the parent, or what would you call this? So this isn't erythema toxicum. It's actually neonatal cephalic pustulosis. That's the fancy term for neonatal acne. So yeah, baby acne. So generally, you're going to see this within the first 2 weeks of life, and it can no longer be considered neonatal acne or neonatal cephalic pustulosis after 6 weeks of age. Generally, you're going to see papules and pustules on the face, though it can extend to other parts of the body. And this is thought to be an inflammatory reaction to Malassezia species of bacteria. And then also due to increased sebum production, most likely due to circulating maternal androgens prior to delivery. Generally, this self-resolves. On occasion, you can have severe enough cases that require treatment with topical 2% ketoconazole twice a day, but generally by the time they become 6 weeks old, this is getting better or it's gone. Now, does anybody know, or what would you call this if you saw this in clinic? So honestly, I'm not seeing any responses, but if I had seen this in clinic, honestly, I would have said the same thing as the one before, baby acne. Interestingly, once you get to be 6 weeks of age, it becomes infantile acne, and that this can last it can onset but up to 1 year of age. It's more commonly seen in males. You still have the same sorts of lesions, but it's more inflammatory papules on the cheeks. You can see true comedones as well. And this can last up to a few years. So most will resolve by 4 years of age. But if you have a baby that has acne particularly on their face or other parts of their body after the age of 6 weeks, and you see other signs of hormonal abnormalities, then you want to get them to a pediatric endocrinologist because there could be something more going on. These lesions can also cause scarring, so it is important to pay attention to that as well. I've never thought to treat acne in young infants, though a lot of times if you don't want this to scar, if it gets severe enough, you do need to treat it. And we'll talk about treatment later, but generally treatment is the same as adolescent acne aside from tetracyclines. Moving on, I don't have as many good pictures because it gets harder to tell age in them beyond infancy, but mild childhood acne or mid-childhood acne generally presents between ages 1 and 7, and this is really rare. It should raise concern for endocrinopathy and does really warrant more evaluation. So you would want to look for causes of hyperandrogenism like Cushing disease, some sort of viralizing tumor, congenital adrenal hyperplasia, and then looking at hormone levels, so your total and free testosterone, dihydroepiandrosterone, and 17-hydroxyprogesterone, in addition to luteinizing hormone and stimulating hormone, because generally you don't see this in this age group. Again, treatment is the same as for adolescents, except for moving on, you can have this pre-adolescent acne that can present between ages 7 and 11. This is less common as well and may require an endocrinology evaluation. Generally, it's due to isolated premature agenarche, but it could be the first presenting sign of precocious puberty, congenital adrenal hyperplasia, PCOS, or a viralizing tumor. Generally, if this is due to an endocrinologic cause, you'll always have other symptoms. So advanced height and weight, body odor, breast development, axillary and pubic hair. And again, this would be earlier than would otherwise be expected. It is important that you differentiate acne versus adenoma sebaceum. These are facial angiofibromas that are seen in tuberous sclerosis prior to age 10, and that's not something that you would want to miss. And this picture, I apologize, it is a little bit blurry, but you can see how these lesions could be misconstrued as more severe acne in a younger child. So it is something to definitely be thinking about and And then finally, we get to adolescent acne. So this tends to present in a variety of ways. As I mentioned before, you can have comedonal acne or blackheads and whiteheads that are non-inflammatory. These are mostly on the face, but you can see them on the back and the chest. And then you can have papulopustular acne or inflammatory acne that can cause hyperpigmentation, kind of as part of the process, but these generally are erythematous papules and pustules that can develop into nodules and then cysts. And if it gets severe enough, these can coalesce into these complex cystic plaques, abscesses, and sinus tracts known as acne conglobata. Looking here, these are just a variety of pictures of different types of acne. The top two pictures on the left show moderate to severe comedonal lesions. You know, these aren't as noticeable, obviously, as inflammatory acne, and I don't know that I necessarily, prior to researching for this talk, would call either of them severe, but it definitely opened my eyes to pay a little bit closer attention to different types of acne lesions that may not be red and huge right in your face. Below that, you've got the moderate mixed inflammatory and comedonal lesions, and then you can see that the guy on the right definitely has severe nodulocystic lesions. And then this is an image of the acne conglobata, so complex plaques, abscesses, and sinus tracts. You can see how big portions of this guy's face are big bumps, and you can almost see the tracts kind of going in the skin and connecting. So this is where you have significant disease and can have significant issues with scarring and whatnot if this isn't treated. Lastly, you can have this rare and severe variant called Acne Fulminans. This occurs almost exclusively in boys between the ages of 13 and 16 years of age. Essentially, you have this abrupt onset of nodular and suppurative acne in association with systemic problems like fever, arthralgias, osteolytic bone lesions, myalgias, hepatosplenomegaly, severe fatigue. You can see elevated inflammatory markers. You can see a leukocytosis. And generally treating these, you would use systemic corticosteroids and isotretinoin. In rare cases, studies have shown that dapsone, infliximab, cyclosporin, and azathioprine have been used and have been successful in treating this as well. This is a picture just showing how severe it can get as far as if we were to get to the point of acne. You can kind of see from onset to healing, but it can get pretty progressive, pretty widespread, and pretty gnarly. As far as pathophysiology of acne, it follows a tetrad. You have inflammation, abnormal shedding of keratinocytes, increased production of sebum, and then association with the Propionibacterium acnes bacteria. From this point forward, I'm going to call it P. acnes because it's a... So looking at increased sebum production, sebum is produced by the sebaceous glands and is associated with increased androgenic activity by both the adrenals and the gonads, and this occurs during puberty. A sebum-rich environment will alter the desquamation and contributes to follicular plugging, which encourages the growth of P. acnes. So all of this kind of coincides, excuse me, with the onset of puberty. Is it still fading? So to talk a little bit further about P. acnes, so this is a gram-positive bacillus. It accumulates in a plugged follicle, and it will release extracellular debris, which is immunogenic and promotes inflammation. So you'll see things like heat shock proteins, porphyrins, proteases, and squalene peroxides. That subsequently attracts immune cells, your neutrophils, monocytes, lymphocytes, causing a local inflammatory response. And then those all contribute to a cascade of pro-inflammatory events inside the distended follicle. It leads to rupture and spilling of the bacterial contents and cytokines into the dermis, which results in the papules, pustules, and nodules, which I've shown. P. acnes can also create a biofilm that can act as a barrier to antibiotic penetration. So that's something definitely to think about when considering types of treatment options, which we'll talk further about. So getting a little bit into the more nitty-gritty of the pathophysiology, this is, and I'm only touching at it because a lot of the medications will target this kind of tetrad. So you have toll-like receptors that recruit these pro-inflammatory cells when they're threatened by pathogens. And then as far as how severe your acne may be, the studies have shown that the more cells that express the TLR2 receptor have more severe acne. And then P. acnes binds the TLR2 receptors, which promotes inflammatory cells toward the pilosebaceous unit to lyse the bacteria. So this is just essentially that in words. So you can see the area, the skin at baseline that is prone to acne with the P. acnes molecules up at the base of the skin. And then you have your TLR receptors that will bind the P. acnes, which activates the pro-inflammatory cytokine release of all of the different cytokines, which are in the C area, and B, your early immune response with your monocytes, neutrophils, lymphocytes, everything's going to be kind of coming to that area and then joining together, and then you get infiltration of the P. acnes into the papulopustule. So evaluation for this, particularly in the adolescent, largely that's going to be your physical exam. And the trick is figuring out, are we dealing with mild, moderate, or severe disease? A lot of physicians will kind of use their own discretion with what they're seeing, but there are some tools that we can use to be consistent as far as determining mild, moderate, or severe. Generally speaking, though, mild disease is limited disease with non-inflammatory comedones, so whiteheads and blackheads, and maybe some minimal inflammatory lesions. Generally, these are on the face, not on the chest or the back, though you can see few lesions there. Moderate disease, you're going to have a greater spread. You're going to have more lesions present. And then severe, you're going to have acne that's already scarred or acne that is more inflammatory that has high risk of scarring. And you may see nodules at this point. This is the primary grading scale that I saw to help determine severity. So this breaks down the different common locations and gives them a factor level, which are those numbers that you see on the right. Below, you can see grading for each of those areas. So looking at no lesions, greater than or equal to 1 comedone, greater than or equal to 1 papule, greater than or equal to 1 pustule, and greater than or equal to 1 nodule. So depending on the grade that you get for that area, you then multiply by that factor, which gives you a local score for each location. You add those together, and then you can see below where the global score falls within all of that. So this is something that helps to be consistent, but it also helps during treatment because you can follow where you started. You can use your baseline score and then follow along and see how you're improving over time as medications are used. So this is where I get completely tied up and why I wanted to do this talk. I feel like acne is very common in adolescents, and personally I've not seen a ton of it in my training here, but feel like it's something that I need to be more comfortable with. And there are so many different options and different ways to treat acne. It is important to let your families know that this is a chronic condition and the goal is to manage the acne and the breakouts, not to actually cure them. Generally, the breakouts will get better as a child gets older. And you must consider multiple different factors when looking at how you want to treat. So it's not just looking at severity, but looking at the severity, the type. Are you dealing with the combined type, more inflammatory, more non-inflammatory? How extensive is it? Is the patient going to be compliant with medications? Does the patient have insurance? What are they able to afford? And then do they have a history of eczema or other sensitive skin conditions that may preclude them from using certain medications? I would just like to preface this slide. I just threw in a Google search, so I have no connections to any of these brand names. I just did this to show how many different options there are. You can see pills, you can see creams, there's all different kinds of things that you can use that are out there, and it's really difficult for people to really figure out, what's the best thing to use, because everything is advertised as this is great for acne, but it doesn't delineate the different types of acne and for what kinds of acne these things are good for. So you can see there are tons of options, and this is just the tip of the iceberg. There's so many more things that you can choose from. So I'm going to start with topicals and move my way down. So the first thing we'll talk about are topical acids. Many of you have probably heard of salicylic acid, or it's a beta hydroxy acid. It has a desquamative effect on the skin. It causes keratinocyte discohesion and congested follicles by dissolving lipid bonds. And so in doing this, it prevents comedones and improves the appearance of those that are already there. This is in many over-the-counter cleaners. It's a popular peeling agent for active acne as well as for acne scarring. Azelaic acid is another, this is a natural occurring dicarboxylic acid. This is bactericidal against P. acnes. It's also anti-inflammatory, and it reduces proliferation of the keratinocytes, and it decreases the comedone formation. So this one is actually not over the counter. It does require a prescription. And then finally, glycolic acid is an alpha hydroxy acid that promotes exfoliation and desquamation of the keratinocytes in the corneal layer of the skin. This is generally used for superficial and medium as a peeling agent, and it does have some evidence that it improves acne scars. And this one can also be purchased over the counter. This is not a bad place to start, particularly with adolescents that have pretty mild cases. And start with a cleaning agent to wash the face, excuse me, with salicylic acid. So moving on, benzoyl peroxide, everybody's probably heard of this. This is largely the mainstay of a lot of our topical treatments for acne. This is a bactericidal agent against P. acnes. It releases oxygen-free radicals and lyses the cell wall of the bacteria. It also has comedolytic properties. The thought is that it decreases the accumulation of free fatty acids in the skin, and it enhances follicular desquamation and decreases follicular plugging. It's generally applied as a gel, 5%. And what's really cool with this medication is that it's been used for many, many years, and there's no resistance ever reported against the P. acnes. This is also in many over-the-counter cleansers. It's in anti-acne creams, gels, spot treatments, soaps, water, or washes, lotions. It's pretty much everywhere. It does have some adverse effects. It can cause stinging, burning, peeling. This can be mitigated with non-comedogenic moisturizers and the decreased frequency of use. So, once a day or once every few days, not using it as frequently. It can also cause allergic contact dermatitis. It's pretty rare, but you can see redness, swelling, and itching. And then it is important to talk to families about this medication because it can bleach anything that it touches. So clothing, bedding, towels, and that could be a rude surprise to families when child uses a black towel and all of a sudden all the towels are ruined. And then, as we'll talk about more, benzoyl peroxide is very commonly used in combination with a variety of other topical agents. So you can also use topical antibiotics. As I said, these are usually in combination. They can be in combination with benzoyl peroxide or a retinoid product, typically adapalene, which we'll talk a little bit more about on the next slide. Most commonly, you're using clindamycin or erythromycin. Dapsone is the newest available topical antibiotic. This is a sulfonamide. It inhibits bacterial synthesis of folic acid and exhibits anti-inflammatory effects by targeting the neutrophil, which also decreases the inflammation. This can also cause peeling and redness. But generally, this is approved in kids greater than 12 years of age. You can do it once or twice a day, and it seems to work very, very well. Retinoids do, so the adapalene does seem to be more irritating to skin, and you don't want to use prolonged monotherapy. It's better as a combination. So moving on to topical retinoids, these are derived from vitamin A. They're a synthetic compound that plays a role in cell differentiation and growth. They'll bind to specific retinoid receptors in the nuclei of the keratinocyte of the skin. And they're extremely effective at normalizing the exfoliation of the epithelial lining of the follicle. With improved exfoliation, this discourages follicular plugging, which prevents the formation of microcomedones. So you get less true comedones and inflammatory lesions. And the exfoliation also promotes the clearance of existing lesions. Retinoids are also comedolatic, and they create an aerobic environment, which is noxious to P. acnes. By blocking several important pro-inflammatory pathways, including the TLR pathway and activator. So moving further into that, tretinoin is a first-generation retinoid. It is extremely photolabile, meaning that it makes your skin far more sensitive to the sun. And it's recommended for nighttime use, so at bedtime if you're going to use it. Then tazarotene and adapalene are your third-generation retinoids. These are more receptor selective. You still have photolability, but it does seem to be a little bit better. This is generally a once-daily therapy, and it's important to mention to families that the first month of therapy could actually cause paradoxical worsening of lesions, so things may get worse before they get better. And the reason for that is that the medication will loosen deeper comedones, which then kind of come up to the surface and kind of come out, so you see more. You tend to have more pimples. They do have a lot of adverse effects and things to think about. So these are most commonly or more likely to cause peeling and irritation. It's important to start with low concentrations and increase slowly. You can do them less frequently, so a couple times a week to start, and then increasing frequency if acne becomes more severe. It's important to use with daytime moisturizers and sunscreen during the day or with any sun exposure. Retinoids are teratogenic even in their topical form, so we cannot use them in pregnant women. And because it does make the skin more sensitive, it's important to tell patients that they really should not be pursuing any sort of waxing, laser therapy, electrolysis, or exfoliation of any kind at the treated sites, because it can cause more damage than. And then moving on to combination therapies. So these are really helpful. It's taking multiple medications and putting them into one. You generally will use them in mild to moderate disease or as adjuncts to oral meds in severe disease. They are appropriate for first-line therapies across the board, but they're more expensive. So it is important to pay attention to what insurance the patient has. Generally, these are mixed. It's benzoyl peroxide mixed either with a topical antibiotic or a retinoid, though you can also have a retinoid mixed with topical antibiotic. Talking about systemic antibiotics, these are generally used for anti-inflammatory properties as well as antimicrobial properties against P. acnes. The main ones that we use are tetracyclines, hormonal therapy, and isotretinoin. Tetracyclines work by inhibiting bacterial protein synthesis and lead to a bacteriostatic mechanism of action. These we don't want to use in children less than the age of 9, which we all know due to the concern for dental staining. And most commonly, as far as side effects, you're going to see photosensitivity. So skin is very sensitive to the sun, GI upset, and rarely you may see pseudotumor cerebri. Doxycycline is most commonly used. You can use once to twice daily, and they actually do have an extended release once daily medication or formulation that can be used that was made to mitigate the GI symptoms. It was initially used as low dose to treat rosacea, which led them to trying to see if it would work for acne, and it does seem to help. Minocycline can also be used. It does have significant side effects. It's not preferred. It's used to treat other dermatologic conditions, including rosacea and perioral dermatitis. But you can see nausea, vomiting, dizziness, phototoxicity, blue-black discoloration of the skin, nails, teeth, bones, and mucous membranes. You can get a lupus-like reaction, and then you can also get eosinophilia and systemic symptoms, as you would see in DRESS syndrome. You can also cross the blood-brain barrier, and you don't want to use it in combination with isotretinoin because it can. That's where you're going to see your pseudotumor cerebri. These meds are generally trialed for 12 weeks, and you can titrate up or down depending on how they do in that time period. But it's not something that's meant to be for long-term use. You really want to get acne to a point where it's controlled and then try to use topical medications after that. So minocycline also can cause this hypersensitivity syndrome. Usually will occur within 6 to 8 weeks of starting therapy, and it begins with a flu-like malaise and a morbilliform rash. But you can see end organ failure, most commonly in the liver, but it can involve the kidneys, the heart, the thyroid, the brain, and the lungs, really any system. So generally speaking, we want to avoid minocycline, stick to the doxys. Hormone therapy. So generally, this is divided into 2 different types. So you have your androgen synthesis inhibitors, so estrogen and progesterone combination pills. So these are your birth control pills, and then androgen receptor antagonists. You can use spironolactone, flutamide, cyproterone acetate. I really only saw studies looking at spironolactone. I didn't see much for the other 2, but this is particularly useful if acne is a result of some other sort of endocrinologic abnormality, such as PCOS. These do take a little bit longer to see improvement, so it may take up to 6 months. And once a patient stops taking these medications, the acne can actually come back. So it's important to let them know that. These are generally reserved for women. Obviously, hormone therapy is not really used in men. They generally will use other modalities. But touching a little bit more at how oral contraceptive pills work, these tend to benefit postmenarchal females who have acne, and the goal is to reduce the stimulation of the sebaceous glands to decrease the sebum production. What studies have been done, it does seem to help more with people of older onset acne, so acne that develops in their 20s, that's located primarily on the lower face and jawline, more kind of on the chin during menstruation. Again, we've seen positive effect on acne in menarchal females, though there's nothing to show. These are all looking at women under the age of 35. They don't really include smokers or anybody with a history of hypercoagulability or thromboembolism, because those are, or pregnant women, because these are people that you wouldn't prescribe oral contraceptive pills. And then lastly, we've got isotretinoin. A lot of you have probably heard of this as Accutane. this is for primarily treatment of nodulous cystic acne. This is kind of when you've run out of all of the other options and acne is getting worse and worse and worse, this is what you're going to use. This is the most effective to treat recalcitrant and severe disease. It's the only medication that I've presented that affects all components of the acne tetrad, and it's the only medication with a curative potential. So this can actually cure or stop further acne once you've completed your course. This medicine is metabolized to tretinoin, which binds to the retinoic acid receptors, and it's extremely effective at decreasing sebum production by inducing apoptosis of the sebocytes. And it also alters the bacterial environment of P. acnes so that it will no longer grow. This you only will use for a total of about 20 weeks. It's extremely teratogenic. So there's a lot of monitoring that goes along with this. And it also has some pretty serious adverse effects. So every patient that takes this medicine is going to experience generalized skin and mucus dryness, so dry lips, dry mouth, and then very, very dry skin. They may also experience muscle aches, decreased night vision, photosensitivity, and you can see cholesterol and liver enzyme abnormalities. Those are typically transient, but it's something important to follow. So the recommendation is that you get monthly baseline labs for the first 3 months, then every 3 months thereafter. They do recommend monthly pregnancy screening for females, in addition to 2 different forms of birth control recommended at the time of starting Accutane. And then if a patient were to become pregnant during the time of being on Accutane, you would want to stop it immediately. This should not be used with tetracycline, which I said earlier, due to the risk for pseudotumor cerebri, and there have been some studies to suggest that this may be connected to depressed mood. So you should do some depression screening throughout the course of treatment. Though other studies have shown that as acne improves, then people's mood does get better because the acne and their appearance could be contributing to their mental health. And then also women have been told historically to avoid any sort of dermabrasion or other resurfacing techniques on their face, particularly until at least 6 to 12 months after completion of therapy. The thought there is that there's a perceived risk of difficulty healing and keloid formation, but it's not entirely clear if this is true. So to kind of bring that together, because you have so many different options, it's kind of where do you start? How do you determine what you want to do? And I think part of it, honestly, is getting into your own practice and figuring out what you found that works with your patients. And there's a lot of different ways to approach it. So the next 3 slides kind of show different ways of thinking about it and how to divide up what you want to use. So looking first, you can think about it as far as, do we have mostly non-inflammatory versus mostly inflammatory, or a mixed picture? You're gonna, if it's non-inflammatory, they're recommending more topical retinoids with the benzoyl peroxide. If there's inflammatory, you're more likely to have more of the P. acnes, so you're going to do more benzoyl peroxide with a topical antibiotic. And then if it's a mixed picture, then you may think, a little bit of all 3 of those things, or systemic treatment in addition to, so maybe an oral antibiotic and a topical retinoid with benzoyl peroxide. You could also think about it as far as severity. So more mild disease, you're going to look more at topical therapy. Moderate disease, you may use topical and an antibiotic or hormone therapy. And then severe, then you may get into thinking about isotretinoin. Again, thinking about extent, and some of this goes hand in hand. If you're just on the face, generally you may be more mild, so you can start with just topical therapy. If it spreads from the face to the chest, then maybe you're going to use topical and an oral antibiotic. And then if widespread, maybe you're going to use, again, topical and antibiotic, or maybe you're going to consider isotretinoin. It is important to think about medical compliance. So is your patient going to use the 3 creams that you're prescribing? Is the patient going to take a pill twice a day? So it is important to think about those things. If you have someone that is compliant and they're really motivated to get rid of their acne, then maybe they will be fine to use multiple medications at different times throughout the day. Or if they're not, then maybe you want to use a combination therapy where they're going to get more bang for their buck out of the medication, because if they're using it once a day, at least it's better than them using none. And then lastly, as I've mentioned previously, you do have to think about what's covered and what's not. So if you can get them combined fixed dose combinations, they're going to be using less medicine as opposed to having to have everything separate, that maybe it's cheaper separate, but it's more work on the patient side. And then retinoids in particular are seem to be the most irritating. So if you have a patient that has a history of sensitive skin or eczema, you may not want to use a retinoid, or you may want to use milder, so lower dose or less frequent application to help with tolerability. Because if the patient's going to be irritated, then maybe they don't want to use it because they were more comfortable before, even though their face didn't look exactly. So some non-medical things that people can try. So hygiene is obviously important. We all need to practice good hygiene. And the thought is that washing your face may remove excess sebum and debris. However, there's not a lot of data to strongly support the role of cleansing with acne in particular. Obviously, wearing makeup and not taking makeup off, that's a whole nother issue. But this is just a clean, like your face with nothing on it. There's not a lot of data to show that washing your face is going to make a difference with your acne. Overzealous washing, if you're using a harsh or abrasive product, you're using a lot of those things that are advertised for women, the different like face brushes and things like that. That can be abrasive to the skin. It can irritate the skin, and it can strip it of its moisture, which can disturb the barrier function of the stratum corneum, which actually may encourage more sebum production. It's also important that we tell our patients not to pick at their face, to use moisturizers that aren't going to clog their pores, to not do things like those face brushes that cause mechanical friction, because all of those things can lead to scarring. You don't want to wash the face multiple times a day. It can dry the face out and make things worse as well. All of these things can cause worsening scarring. And actually, there is a syndrome called acne excoriae, which is a compulsive syndrome, which can be a component of body dysmorphic disorder. It's more common in young girls, but it's where they are constantly picking at their face and trying to get rid of any blemish, and it can actually lead to their face looking worse in the long term. Diet is another thing that has been studied and look at in association with acne. Both the Western diet and puberty upregulates insulin and insulin-like growth factor 1, which exaggerates sebaceous gland cell proliferation and contributes to increased sebum production. The Western diet does have a high glycemic index. I did see that one study saw an improvement in skin as a patient's BMI decreased over 12 weeks, in addition to a low glycemic index diet. So being overweight may cause more acne, as well as eating more sugar. And then another study showed that the total dairy intake in patients, the higher it is, the worse their acne tended to be. Some other foods to think about that may worsen acne: seafood, particularly saltwater, fish and other types, shrimp, cow's milk containing dairy items, iodine containing foods, and androgen boosting foods, which can be certain fish, egg yolks, fortified cereals, oysters, beef, beans. And that's because androgens lead to more sebum production, and then excessive iodine is secreted in the oil glands and can irritate your pores. There are substitutions that you can use for some of these things. So instead of cow's milk products, try goat milk, goat cheese, feta cheese, sea salt rather than iodized salt, almond butter rather than peanut butter, and healthy oils like olive oil, coconut, avocado. May help. You still really need to to have something like topical else, but it may help with flares and breakouts. So there are physical treatments. Everybody's probably heard of Dr. Pimple Popper. This does improve physical appearance and can improve the penetration of topical medicines. She does a lot of comedo extractions, so using a specialized device and physically removing the debris from the comedones. You can, under sterile conditions or with a sterile blade, nick a closed comedone to ease the expression of the contents, but this should really be done in a controlled setting. This should not be done individually. I know a lot of us like to do it. It's not uncommon, but it should be done by a dermatologist and should not be done ever on an inflamed lesion. The adverse effects of this, you can have bruising and you can develop scarring. Some people will use an intralesional corticosteroid injection. These are primarily for nodulocystic lesions. You use a high concentration of triamcinolone. And the goal here is to flatten the lesion and decrease surrounding inflammation. It can take up to 72 hours to see any kind of effect. And it does have some significant adverse effects, including atrophy, telangiectasias, striae, and pigmentary changes. So it's not without its own risks. And then very, very rarely, some people have tried cryotherapy, though there's not a lot of evidence to support that it's a good option. So most of what I've talked to you about up to this point is really trying to get to this maintenance phase. So each treatment that we try should be trialed for 2 to 3 months and then advanced or tapered. Oral meds, except for the OCPs, have a finite treatment time. So doxycycline, you really don't want to use for longer than 6 months. You want to use until you get the acne under control. Then it can be used as needed for breakthrough flares, but not daily. And you want to continue topical medications for maintenance. OCPs, given that they're used for a variety of different things, those can be used indefinitely. And then, like I mentioned before, isotretinoin, you don't want to use longer than about 20 weeks. So about between 4 and 5 months. And then once everything is under control, you want to try to keep and maintain everything with just topical meds. And generally, topical retinoids are most commonly used for long-term maintenance. The initial discomfort and irritation does tend to get a little bit better the longer they're used. So you tend to continue those. So just real quick, I've alluded to different scarring as a complication of acne. I had no idea, but there's actually 4 different types of scars that you can see. So starting on the far left, you can have what's called boxcar scars. So these are shallow indentations with more defined edges, and each individual scar is easier to see. Interestingly and important to note, this is an atrophic scar, as well as the ice pick scar. Ice pick scars are thin and narrow. That's on the chin there. They're deep, and they're the most difficult to treat and hide. And this is due to really severe inflamed cystic acne. So this is what we're trying to prevent with those that have the worst acne that we can see. Moving on to the right, you have the keloid, I guess I think that's misspelled, sorry. Keloid scars. These are hypertrophic, they're raised, bumpy, and they mimic acne, though they're not red or inflamed. This is the result of the body trying to heal, but it's caused by proliferation of cells and collagen. So kind of the reverse effect of what you want to have happen. And then finally, on the far right, you have rolling scars, and these are very shallow indentations of the skin. And it's kind of multiple scars rolled into one uneven surface. And this is due to the damage of the skin and lack of collagen. And these actually can get worse with age. And then lastly, it's not on this picture, but anywhere that you have had acne, you can see hyperpigmentation. These are kind of like macules that lie flat on the skin. It looks like a discolored pigmented mark, and it's left due to overproduction of melanin. It can be worsened by exposure to the sun, and it's more prominent on non-white skin. So There are some treatments, though there's no gold standard because the results tend to be mixed and unpredictable. Um, a lot of these treatments are called cosmetic camouflage, which generally is helping with the redness, any post-inflammatory dyspigmentation, and the atrophic scars. So those are your ice pick and boxcar scars. So three of the main things that are tried is dermabrasion, which is a special motorized tool that has an abrasive surface, and the idea is that you remove superficial layers of skin. And this creates a wound that encourages healing and lays down new collagen. You can have redness and swelling as a result of this for weeks. So it does have its own kind of side effects. And then dermal fillers is hyaluronic acid injected into the scars. Similar idea. And both of these, in order to have long-lasting effects, have to be repeated every 6 to 9 months. So it's not a one and done kind of thing. And then lastly, you have subcision, which is a small needle that's introduced into the periphery, so just outside of an atrophic scar, and it's kind of moved back and forth. And the aim here is to release the scar from its tethered base, and the subsequent bleeding is thought to recruit new collagen formation, which can kind of act as a filler to improve the appearance of the scar. Another modality of therapy that people have tried is laser and light therapies. Again, there's not a whole lot of data here behind these, but pulse dye lasers are used most commonly for vascular lesions, though people have tried them for active lesions, not scarring, but kind of active lesions. And these target the redness or the erythema of the acne. Though there have been a few studies that have showed no significant difference with this versus the placebo. So it's unclear really how much it actually does. Light-based therapies, generally you're using a red or a blue light. The thought here is that you're reducing P. acne levels by targeting their bacterial porphyrins. But the improvement, instead looking at this, has only really been marginal. So it doesn't really seem to help a whole lot. Carbon dioxide lasers seem to be the best option at this point, though more studies need to be done. It seems promising, though. These lasers penetrate only the epidermis and the upper dermis of the skin, and they create thermolysis and then encourages growth of new collagen. This, though, can cause redness and swelling. So now I have some questions. My first question is, a 6-year-old boy is brought to the clinic for evaluation of mild acne. As an infant, he had acne that resolved on its own. Recently, the mother has noticed that the acne has recurred. In addition to assessing height and weight and a complete history and physical exam, which of the following is the next best step in management of this patient? A, obtain total and free serum testosterone, dehydroepiandrosterone, 17-hydroxyprogesterone, and luteinizing hormone and follicular stimulating hormone levels. Reassurance, no treatment is necessary because this condition is benign and will spontaneously resolve. Start the patient on benzoyl peroxide facial wash and anti-acne soap. Start the patient on topical retinoid, or skin biopsy of one of the lesions. Feel free to call it out or put it in the chat. So Dr. Tamez said A, that is correct. So given that this child is 6, he's had recurrence of acne. As far as we know from the question stem, we don't have any other symptoms of a endocrinologic process, but we need to work him up for it because at his age, he should not be having acne. All right, next question. A 15-year-old girl is brought to the clinic for evaluation and treatment of her acne. On physical exam, she is noticed to have severe non-nodulocystic acne. She has been previously referred to dermatology and was prescribed oral tretinoin. The patient admitted that she has not filled the prescription as she is not comfortable taking oral isotretinoin due to adverse effect concerns. She was wondering whether there are other suitable alternatives. Her current treatment regimen includes benzoyl peroxide, topical isotretinoin, and oral antibiotics for breakthrough lesions. Which of the following is the most appropriate plan of care for this patient? A, add oral contraceptives to her current regimen. B, add topical dapsone to her current regimen. C, caution her that oral isotretinoin is the only best option for long-term control for her. D, continue her current treatment regimen, or E, recommend a trial course of topical adapalene with benzoyl peroxide gel and oral antibiotics. So I thought the answer was A too when I was doing these questions myself. However, because she is currently she's got non-nodulous cystic acne, so it's not inflammatory. And then it also she's using oral antibiotics only for breakthrough lesions. So what they wanted and what we should do is to maximize the topical and oral meds that she's already on before adding another one. So trial course of the adapalene instead of the isotretinoin mixed with benzoyl peroxide, and then doing oral antibiotics daily as opposed to just for breakthrough. So the correct answer was E, but I was not a huge fan because I thought it was A as well. I don't think it would be a bad idea, honestly, to add oral contraceptives. I think that would be a fine thing to try, but what they were getting at is maximizing what she was on because it was helping, just not quite enough. And then lastly, a 13-year-old boy with mild comedonal acne and oily skin is brought to the clinic for management. He denies sexual activity. His sexual maturity rating is Tanner stage 2 to 3. Besides non-pharmacologic treatment, which of the following is the best next step in the management of this patient? A, medium strength topical retinoid daily. B, mild retinoid ointment every other night to twice per week. C, no treatment should be added at this point. Continue washing the face twice a day. D, oral doxycycline, or E, oral isotretinoin. Yeah, the answer here is mild retinoid ointment every other night to twice per week. So you want to start kind of low and slow and see how he tolerates it, and then see what his acne does, and if we need to increase, we can, but right now he has mild non-inflammatory acne, so it's entirely fine to start there. I think I had a question about the question before. So pending compliance concerns or wanting to do all regimen. So yeah, I think part of it is also compliance, using what she already has. She's already used to taking those things versus adding another medication on top of it. Again, I probably should have taken that question out because it's not a great one, but I liked it in part because I did get it wrong. But it was, I think part of it too is that it wasn't pointing, and what I was finding that the hormonal acne tends to be more related to inflammatory acne. And so seeing if that can, because she was not having inflammatory acne, to see if that made the topical things made it. And then lastly, my references. And then for those that specific duration of use for oral antibiotics, yeah, so you don't want to use oral antibiotics for more than 6 months. So the idea is that you get to a good spot with control, and then you can use the oral antibiotics PRN like as needed for, say it gets bad, here and there, then you can use them as needed for like a week here or there, but you don't use them continuously. That goal is to get to all topical for maintenance and to maintain that. So for those of you that don't know, my husband lives in Colorado, and I will be moving there in a month. And this is my dog Huckleberry. So these are some pictures over the years. He's been there this is the 7th year. So we're finally getting to live together. That's him in the top right. But that's where I'll be headed here soon. He is going to be a mountain dog, Dr. Schmitz. He loves it. Does anybody have any questions? Thank you all for your time. I really appreciate it. And I will miss all of you dearly. I hope you have a good rest of your day.